History and physical examination. Even with major advances in medical technology, the history remains the most important part of the clinical decision-making process. Studies show that physicians make a diagnosis in 70%–90% of cases from the history alone. It is important to remember that the history is explored not only with the patient, but also, and with consent if required, from all available sources if necessary. For example, paramedic and emergency department notes, eyewitnesses, relatives and/or carers. However, clinicians need to be aware of the diagnostic usefulness of clinical features in the history and physical examination. For example, students are often taught that meningitis classically presents with the following features: headache, fever, meningism, photophobia, neck stiffness and other signs of meningeal irritation, such as Kernig's and Brudzinski's signs. However, knowing the frequency with which patients present with certain features and the diagnostic weight of each feature are important in clinical decision-making. Many patients with meningitis do not have classical signs of meningism, and the clinical presentation varies among different patient populations and in different parts of the world. In one prospective study conducted in the United States, nearly all adult patients with meningitis had headache and a fever, but less than half had neck stiffness on examination and only 5% of patients had Kernig's and Brudzinski's signs. All three signs had a likelihood ratio of around 1. Meaning their presence or absence was of little use in deciding whether a patient had meningitis or not. Fig. 1.2. Likelihood ratios (LR) are clinical diagnostic weights. An LR of greater than 1 increases the probability of disease. The higher the value, the greater the probability. Similarly, an LR of less than 1 decreases the probability of disease. LRs are developed against a diagnostic standard. In the case of meningitis, lumbar puncture results do not exist for all clinical ND-ings. LRs illustrate how an individual clinical ND-ing changes the probability of a disease. For example, in a person presenting with headache and fever, the clinical ND-ing of neck stiffness may carry little weight in deciding whether to perform a lumbar puncture because LRs do not determine the prior probability of disease. They re-ECT only how a single clinical ND-ing changes it. Clinicians have to take all the available information from the history and physical examination into account. If the overall clinical probability is high to begin with, a clinical ND-ing with an LR of around 1 does not change this. Evidence-based history and examination is a term used to describe how clinicians incorporate knowledge about the prevalence and diagnostic weight of clinical ND-ings into their decision-making. In studies, students who are taught the probabilities of features being present in Specie C diseases rather than lists of features have better diagnostic accuracy. This is improved further by understanding the basic science explanation for symptoms and signs. Bedside signs of meningism identify patients with severe meningeal inamation but do not pick up those with early or mild inamation. Evidence-based history and examination is important because estimating the clinical, pre-test, probability is vital not only for diagnostic accuracy, but also in the use and interpretation of diagnostic tests.